Hi again. So today we're going to learn about part 2 of chapter 37, which covers things like hydronephrosis and polycystic kidney disease. We're going to go over chronic kidney disease and acute kidney disease and talk about hemodialysis versus peritoneal dialysis. And the PowerPoint goes along with the lecture. So the first slide, hydronephrosis. If you remember from the previous lecture, I talked about, the anatomy of the kidney. And the anatomy of the kidney, the renal pelvis is the lowest portion of the kidney that actually becomes the ureter, which is that tube that goes from the kidney to the urinary bladder. And I told you it holds about 15 to 30 milliliters of urine, which is a teeny tiny little bit. So if that ureter becomes obstructed for whatever reason, then the urine can't flow out. And so as the urine backs up, you'll get what's called hydronephrosis. And so it's an obstruction that causes that urinary backup. And as the urine backs up, the kidney is going to start to swell and enlarge. And the pressure inside the kidney is going to increase. And it actually can cause permanent kidney damage, which you don't want. With hydronephrosis, there are a few pictures here so you can kind of see the damage that can happen to the kidneys as they start to enlarge and swell up. A patient can even wind up a dialysis patient. So signs and symptoms, frequency, urgency, dysuria, flank pain, back pain. And, with the urgency, people are frequently running to the bathroom. I have to go now. Drip, drip. Just a little bit of urine, right? They never feel like they've completely emptied their bladder. And so, the primary way to treat it, as far as therapeutic interventions, treat the cause. So, if it's urinary retention because of the bladder, then certainly a urinary catheter would be appropriate. If it's because of an obstruction in the ureter, then there would be possibly a stent put in. And remember, the word stent it's a small kind of a mesh-looking tube, basically, that goes into, can go into the ureter, can actually go in a coronary artery too, but it opens up that part of the body. So with the ureter, it would open up the ureter and allow for the urine to flow from the kidney into the urinary bladder. Now, if the ureter is actually damaged to the point where a stent won't work, a nephrostomy tube is something that might be placed. A nephrostomy tube is a tube, thin catheter that literally goes in through the flank of the patient directly to the kidney. Okay. Primary nursing interventions for these things. And by the way, whenever there's any kind of a drainage tube that's coming from a patient to the outside world, whether it's a urinary indwelling catheter in the bladder, whether it's a nephrostomy tube, whether it's a type of wound drainage device, doesn't matter. The first priority nursing assessment is make sure that the tubing is patent and not kinked, okay? And make sure that the area at the insertion site of the tube is free from signs and symptoms of infection, which would be something, swelling, redness, erythema, purulent drainage, okay? And whenever we are draining urine from a patient, whether it's through a bladder catheter, indwelling catheter, or a nephrostomy tube, you're always going to be measuring intake and output. That's very important. Renal trauma, I'm going to talk about this briefly. Patients on a ladder, working on their roof, and they take a fall and they land on their back. So the first thing you may think of is back pain, right? Maybe they injured their spine. They could also do damage to the kidneys because of their location. Anatomically, where your kidneys are located, they're located at the bilateral flank area, and they're actually covered by kind of a little layer of fatty tissue that acts as a shock absorber, right? Kind of a cushion to protect them. But they can get injured as well. So signs and symptoms would be bruising, swelling at the area, at the flank area, pain, bloody urine, which is hematuria. And as far as diagnostic tests, most often it's going to be something like either an MRI or a CT scan where we can actually look at the innards of the kidney to see what kind of damage was done. And then as far as interventions, we're going to, treat whatever the injury is. and make sure we're managing the patient's pain, I&Os, vital signs, and IV fluids. All right, next on the hit list is polycystic kidney disease. So poly meaning many, cystic, cysts, okay? Polycystic kidney disease is a disorder that's hereditary, runs in families. And what happens is the patient will develop cysts, multiple cysts in the kidney. Signs and symptoms usually are a dull, heavy feeling in the lower back or flank area. Hematuria. Hematuria is a sign of a lot of different things. Hypertension. Because of those cysts that are in the kidneys, it affects the renin, angiotensin 1, angiotensin 2, aldosterone, antidiuretic hormone system in the kidneys that maintains the balance of fluid and maintains your blood pressure, right? So with polycystic kidney disease, one of the first things that gets affected is your blood pressure because fluid's not being managed appropriately. Sadly, with polycystic kidney disease, there's really not a treatment. There's not a cure for it. It is progressive and it is degenerative. So in other words, it's not going to get better. It's only going to get worse. Progressive, that's what that means. And degenerative, it means that there's going to be more breakdown of the kidney. When we start talking about chronic kidney disease and renal failure, people that are on dialysis or on hospice, the number one reason for damage to kidneys, diabetes. Diabetes is the most common cause of all kidney disease that there is because every time blood sugar is elevated, the sugar that's in the blood is just eating away at the blood vessels, little teeny tiny blood vessels to the kidneys, also to the eyes, also to the feet and legs. And because of that damage to the blood vessels, blood deprivation to the kidneys, well, that winds up causing permanent damage. The number of people that require dialysis in this country, number one statistical reason is diabetic nephropathy. In other words, kidney damage secondary to uncontrolled diabetes, which is sad. So, therapeutic interventions. The number one way to not have this happen is to control blood glucose. I can't say this enough. Diet and exercise, diet and exercise, diet and exercise. So, it's not the diabetes itself, but it's the sugars that become erratic. Every time those sugars spike in the blood, a little bit more damage is happening to your kidneys. And, as time goes on, the damage becomes irreversible. Okay? And it comes to a point where with chronic kidney disease, once you get to stage 5, there are 5 stages of CKD. Stage 5 means your kidneys have shut down. They're just not working anymore. And your choices are dialysis, kidney transplant if you qualify, or if you are not a qualified recipient or candidate, for the list for transplant, maybe you have a family member that's a match that's willing to donate a kidney to you if you're lucky. Otherwise, the only other option is hospice. Without your kidneys, you will die. The number one teaching thing that we can do for our patients is to teach them to control their blood sugars and also, of course, control their blood pressures. Nephrotic syndrome, I'm just going to go quickly through this too. Nephrotic syndrome happens because of damage to the kidney, and it can happen for different reasons. One of the first signs is proteinuria, or large amounts of protein that are found in the urine. Part of what your kidneys are supposed to do is reabsorb protein because you need protein. And when your kidneys aren't working properly, instead of reabsorbing the protein, they excrete it and it spills into your urine. And that's why we will see positive protein in the urine. And because you're losing protein through the kidneys, through your urine, you're going to see your serum albumin, which is your number one plasma protein, start to go down. When the protein levels go down, we're going to start to see edema. Patient's going to start to swell. And because the body's always trying to compensate, one way or the other tries, you're going to see LDL, which is the low density lipoprotein, the bad cholesterol, and triglycerides, fat in the blood. Both of those things are going to start to increase. So basically, the patient becomes kind of a walking, ticking time bomb, and it doesn't get any better. Nephrosclerosis, that is caused by sustained high blood pressure. So nephro meaning kidney, sclerosis or sclerotic. When something becomes sclerotic, it becomes stiffened or hardened, and your kidneys aren't supposed to be as hard as bricks, right? They're supposed to be soft tissue. When they start to get damaged, they will start to build up like scar tissue, and then they won't be able to do their job as filters and everything else that the kidneys are supposed to do. And really the biggest cause is hypertension. Remember, back from term 3, way back when, hypertension, we call it the silent killer because you're asymptomatic. So your blood pressure could be sustained at a very high level, but you're not going to feel anything. When people start to complain of things like these dull, persistent headaches or even nosebleeds, epistaxis, we've missed it. That blood pressure has been high for a long time. And with those high blood pressures that are sustained, they are literally just beating up the kidneys, beating them up. The only thing to do with this is control the blood pressures, right? And prevent the damage from being done, okay? Blood pressure, blood sugar, blood pressure, blood sugar. I know I sound like a broken record, but if you exercise and you eat reasonably well and take pretty good care of yourself, you can get through without any of these things happening. The next thing is glomerular nephritis. I did not highlight it because I don't want to get into real specific detail about this one. It's an inflammatory disease of the glomerular apparatus, the glomerulus, which is inside the kidney. That's part of the filtration system. It gets a little complicated where the antibodies are actually kind of attacking the membrane. Your own antibodies attack the membrane of the glomerulus. And when that happens, things start to spill into the urine that aren't supposed to be in the urine. Remember, when you're looking at a urine analysis, there should never be protein. There should never be protein in the urine. There should never be ketones in the urine. There should not be glucose in the urine. End of story. And again, with glomerular nephritis, there are some causes like acute post-streptococcal infection for some people that have severe streptococcal infections. And yeah, like strep throat, that's a streptococcal infection, but there's also group beta strep. There's lots of variations of streptococci bacteria. And for some people, after they have the infection, then things like glomerular nephritis, even other things can happen after the infection. So again, you can certainly read about it. I'm not going to get into grave detail about this one. We have bigger fish to fry. So we're going to move on to acute versus chronic. And we're starting with acute kidney injury. And remember, when we talk about something acute versus something chronic, acute is a boom. It's like a ton of bricks. It's a sudden onset of something. It's usually short term, but it can cause a lot of damage. And then something chronic means that it is there to stay. Sometimes symptoms will wax and wane. In other words, they'll get worse or a little better or a little worse or a little better. But the disease doesn't go away if it's chronic, right? With acute, you can recover when we're talking about kidney injury. So boom, ton of bricks, a sudden loss of kidney function. Your kidneys they're not working. And we'll get into the reasons why in a minute. Azotemia is a word that you should know. Azotemia, when you hear emia, you think blood. And so azotemia is an accumulation of toxins in the patient's bloodstream. Kidney's injured, kidney can't work right, supposed to be filtering toxins out into the urine, can't do that. Toxins are spilling back into the bloodstream. And obviously that's not good. It can cause something called uremic frost. Google image it. It really is something to see the first time that you see it. It looks like someone has been out in an ice storm, right? They literally look like they're covered in frost. In the winter, when you go out to start your car and your car's covered in frost, your windshield, that's what the patient's skin looks like. Because all those toxins, the azotemia, toxins in the blood are slowly seeping through the patient's pores, through their skin, and they get this frosty look. Oliguria and anuria, know the difference. So anuria means there's no urine, no urine. Oliguria is decreased urine production, significantly decreased. The minimum amount of production of urine is 30 milliliters per hour, and that's low. Okay, anything under that, the kidneys are done. If they're running 30 mils an hour, it's still pretty bad. We're very worried. But that's the minimum amount of urine that a patient can put out per hour, 30 milliliters per hour. But again, because it's acute, there's a chance the patient can recover, and it depends on what caused the injury in the first place, okay? And what can cause acute kidney injury? Well, there are lots of reasons. Pre-renal, intrarenal, and post-renal failure. So pre-renal is things like diabetic nephropathy, right? Because there's not enough blood supply to the kidneys. Intrarenal failure, damage to the nephrons, maybe because of an injury. And then post-renal failure can be a prolonged obstruction, like lithiasis. So if the patient had renal calculi and one of the calculi got jammed up in the ureter, or if there was a tumor in the ureter that obstructed it, it would cause, damage to the kidney. Nephrotoxins, this one's important, okay? There are certain things that we need sometimes, but they are known to be damaging to the kidneys. Contrast dye. When a patient goes in for, say, an angiogram or a CT scan with contrast, that contrast dye is nephrotoxic. And so, we always check the patient's BUN and creatinine levels before we administer contrast dye. Of course, in addition to asking them about any allergies to iodine or shellfish. But we're talking about the kidneys. Because contrast dye, in order for your body to excrete it, guess what's responsible for excreting it? Kidneys. And if the kidneys aren't working up to par and we give the patient contrast dye, we could literally put the patient into acute kidney failure. Okay? Meds. Any of the aminoglycosides, tobramycin, right, amikacin, they're all considered nephrotoxic. Loop diuretics, furosemide, bumetanide are also toxic. NSAIDs with prolonged and frequent use can be toxic to the kidneys. And then there are chemicals out there that are considered, toxic to the kidneys. So make sure that you know the medications and you understand, meds and contrast dye and, the fact that they are nephrotoxic. And I am adding some of these other meds to the list as well. Okay? All right. And so what do we do about it? Well, prevention. The bottom line is when it comes to medicine, it's always better to prevent something from happening rather than try to treat it on the back end, right? Because it's going to be harder. You want to make sure, again, when we're doing anything with contrast dye, you're assessing the patient to make sure that we're not inducing a nephropathy with that contrast dye. We're making sure that the patient hydrates themselves. Because the liquid, the increased PO intake of liquid, is going to help to flush that dye out, okay? So make sure you know that. And then with acute kidney injury, it comes in phases. It's the oliguric, diuretic, and recovery phase. You don't really need to know that, but just I'll go over it quickly. The oliguric phase is the worst of it. That's where the amount of urine that's being produced just goes down, down, down. Hopefully we're treating whatever the cause of it is, and then the patient's going to go into the diuretic phase, where the kidney's all of a sudden going to go, oh, snap, we better wake up and start diuresing or start getting fluid out, and then the patient will begin to recover. That makes sense, right? Therapeutic measures for acute kidney injury. Treat the cause, obviously, and then supportive treatment would be maybe IV fluids or whatever. Sometimes the patient will need temporary dialysis. And we're going to talk about dialysis in a couple minutes and the different types of devices that are used. So they may need to be on dialysis, but just for a short period of time to kind of give the kidneys a break until we resolve the cause, and then we can get them off of dialysis, okay? Now we're going to go to chronic kidney disease, which is very bad. So with chronic kidney disease, that means that the kidneys are diseased and it's progressive and it's degenerative and it's irreversible. So, the patient basically is having a slow and steady breakdown of kidney function over time. As I had said earlier, chronic kidney disease, also known as CKD, comes in stages. And so you can't be, say, a stage 3 and then go back to a stage 1. So it's progressive. Stage 1 is going to become stage 2 at some point, which will become stage 3, 4, and then 5. CKD, stage 5, that means that the kidneys have shut down. It's complete renal failure. And like I said earlier, it's dialysis, kidney transplant, you're going to die. One of those 3 options, and that's about it. When we talk about causes, diabetes, uncontrolled diabetes is the #1 cause of renal failure. Can't say that enough. Diabetic nephropathy. Sustained hypertension, also a cause. And then the diseases that I talked about earlier, the nephrosclerosis and glomerular nephritis, if not treated, or if treated late, can cause significant scarring and damage to the kidneys, which can then cause progressive, breakdown of the kidney tissue. And then autoimmune disorders. Now remember, autoimmune disorders, auto meaning self, and immune meaning of the immune system. So with autoimmune disorders, and there are thousands, they all relate to the person's own, what's supposed to be their defense, their immune response, their white blood cells. Instead of attacking pathogens or, bad bacteria or viruses, it attacks that patient, okay? And so there are certain autoimmune disorders. Lupus is one that can attack the patient's internal organs, including the kidneys, and the patient can wind up with chronic kidney disease. I'm not going to get into the pathophysiology very specifically, but just understand that basically the nephrons in the kidneys, which are the smallest functioning unit of the kidneys, are damaged. And it gets worse. And, over time, they are not going to have any kidney function. And let me tell you, without your kidneys, a whole lot of bad things are going to start happening. Because your kidneys, if you remember, are responsible for a whole lot of things: acid-base balance, fluid, blood pressure, manufacturing erythropoietin so that your body can make red blood cells. So it gets bad. Electrolyte imbalances out the wazoo. If you look at a dialysis patient's MAR, medication administration record, your head will explode because they're on a ton of medications. Phosphorus binding medications, and we worry about protein, we worry about hyperkalemia. The list goes on and on. So signs and symptoms of chronic kidney disease are edema, fluid accumulation, and that's going to be like everywhere. Pulmonary edema, which would cause shortness of breath, and then peripheral edema, within the body. Electrolyte imbalances that can really, really be fatal. Remember, potassium, whether it's too high or too low, affects muscle. And muscle, your myocardium is a muscle, makes your heart beat. And with high or low potassium, you can have a heart attack. Sodium levels tend to go up. Calcium tends to go down. Phosphorus tends to go up. Water, and waste is retained. And when that happens, acid-base imbalances start to happen. Well, I don't know. Should I make the bicarbonate? Maybe the kidneys can't make it at this point. And then, of course, anemia, because the kidneys can't make the erythropoietin in order for the person's body to make red blood cells. When you look at this next slide that you're going to see, there's a picture of a woman, and it shows you all the things that absolutely will happen with chronic kidney disease. And make sure that you understand what it is you're looking at. So, it gives a pretty good explanation of what things break down when the patient has chronic kidney disease. When you look at the diagram, you'll see oral cavity. The patient will wind up with a funny metallic taste in their mouth, and they will often wind up with either stomatitis or glossitis. Stomatitis, inflammation of the mouth. Glossitis, inflammation of the tongue. From a cardio standpoint, going to wind up definitely with hypertension, and all that high blood pressure is going to lead to heart failure, and the electrolyte imbalances are going to lead to dysrhythmias. The GI system is going to be affected. Anorexia, they're going to lose their appetite because they're filled up with fluid. Nausea, vomiting, even GI bleeds and ulcers. Reproductive system even gets affected. Sexual dysfunction, so in other words, loss of libido, and the patient can even have infertility issues where they're not able to conceive. Patient can even wind up with neurological symptoms. So they'll feel fatigued, depressed sometimes. They'll have this persistent headache. Remember, electrolytes. Sodium levels start to increase. You'll see confusion. Even seizures, which can lead to coma and death. Respiratory system. Respiratory, they're going to have pulmonary edema because their kidneys aren't able to excrete the fluid in the way that they're supposed to do it. Patient can have symptoms like dyspnea and even a pulmonary effusion where there's so much fluid that the fluid can start to accumulate in the pleural space around the lung, which then puts pressure on the lung and the patient can't take a deep breath. Of course, the renal system, that's a given, that's going to be affected. Anemia, right, we talked about, and oliguria and anuria. So in other words, it starts out with decreased urine, and then it winds up with no urine production at all. Skin. You will find dialysis patients are constantly itchy. They're itchy. Itchy, itchy. Pruritus. And it doesn't matter what you give them. It doesn't matter if you use topicals, hydrocortisone, the itching won't stop. Why? Because it's the azotemia. It's the buildup of toxins in the blood that's seeping through the pores, making the skin itch. So it's coming from the inside, and it's really, very difficult to treat. Ecchymosis, which is bruising. Uremic frost, which I talked about already. Dry skin, and they can even start to look a little jaundiced. Their skin can start to take on a yellow appearance. And then, of course, fluid volume excess. So they're gonna present with edema peripherally and even all the way up the legs, where their legs can really kind of look like tree trunks instead of legs. So make sure that you understand all of those symptoms, clinical manifestations, if you will, of renal failure that's chronic, okay? The next slide talks about what the therapeutic interventions would be. Well, let me tell you, it's very hard to manage a kidney disease patient. It's complex. So diet. They need as many calories as they can get with the smallest amount of food. In other words, more bang for your buck, if you will. So high calorie, low protein, unless they're on dialysis. If they are already dialyzed, getting dialyzed, then the dialysis machine will help get rid of the protein. So they definitely need low sodium because of water retention. They need low potassium and low phosphorus. They need increased calcium because what will happen with chronic kidney disease, the kidneys will start excreting calcium, and so they're going to be at risk for serum calcium levels that are very dangerously low. And remember, when you think calcium and magnesium, think nerves. So they're going to have, that's where the seizures can come in, right? So you got to make sure they're getting enough calcium in their diet, vitamins, and fluid restriction. Know this, when it comes to chronic kidney disease and fluid restriction, 1,500 milliliters per day, okay? Now, a normal healthy adult should drink somewhere between 2,500 and, say, 3,000 milliliters of fluid in a day. So if they're on fluid restrictions because of chronic kidney disease, 1,500. P.S. If they have heart failure, 1,500 mil restriction as well, okay? Medications, diuretics. We're going to give them diuretics to try to get rid of that excess fluid. Antihypertensives to bring the blood pressure down. Talk to you about phosphorus or phosphate binders like Renagels. We give them those. They will bind to phosphorus in food so the patient can excrete it through their feces so that their phosphorus levels don't go high. They're going to need vitamin D and calcium supplements and possibly potassium reducers, right? Remember, K-oxalate is one of the important ones. And then as things get worse, they're going to dialysis, okay? And with dialysis, which we're going to talk about at length, Once they start having these high potassium levels, neurological signs, uremia, fluid overload, they're usually a chronic kidney disease stage 5, and they're going for dialysis because it's either that or hospice, right, or a kidney transplant. And if they're waiting for a transplant, they're going to be dialyzed while they're waiting for the new kidney, right, because we can't let them die in the meantime. So now we're going to talk about hemodialysis versus peritoneal dialysis, okay? And they're two very different forms of dialysis that we'll talk about at length. Hemodialysis. So heme means blood, right? Hemoglobin. So hemodialysis means that we're taking the patient and attaching them to a machine called a dialyzer, and we are going into a vein and an artery, basically filtering all of their blood the same way the kidneys would do if they were working properly, okay? In order to do this, we need some type of vascular access, and we're going to talk about access devices in a minute too. So we can do temporary access, which could be a TLC, right? Central venous line. I'll make you laugh. One of the names for a temporary IV line in the neck is called a permacath, but it's temporary. That always made us laugh. The permacath is the one that's temporary. And then if we know that the patient is going to be on dialysis until they die, we're going to put in an AV fistula or an AV graft, which stands for arteriovenous fistula or arteriovenous graft. Okay, and I'm going to explain the difference between those in a moment too. The next slide shows you a picture of a patient that is being dialyzed. So you see the dialyzer, machines next to them, and they have two lines. So one line's going to an artery and one line's going to a vein. And what's happening is that all of their blood is going from their body through the dialyzer, filtering out the toxins, and then getting pushed back into their systemic circulation. And there's a real person. It's a little more real looking that's, getting dialyzed. That's what those dialyzers look like. So when we talk about vascular access, there are a couple things that you definitely need to know. And one of the most important things is it's an old line, and it's called feel the thrill and hear the bruit. And I'm going to explain what that means. So, and let me highlight this too. So this way you know how important this is. You must know it. The next page is a picture of a fistula and a graft, okay? So an arteriovenous fistula and an arteriovenous graft. Basically, very, very similar, okay? So we'll look at A first, an arteriovenous fistula. It's usually placed surgically in the patient's forearm, and what they're going to do is they're going to take an artery and a vein, large ones, and they're going to put them together and create a fistula or like an opening, like a tunnel between the two of them. It's surgically created. Once that's been done, takes a couple of weeks for it to heal. And once it's healed, what's happening is every time they go to dialysis to get dialyzed, there are two needles with catheters, and they must get poked in each side, one in the venous side and one in the arterial side, right? And so that the blood's coming from the body to the machine and then from the machine back to the body, okay? So that's a fistula. The next type is a graft. And it's the same principle, surgically implanted. The difference is with the graft, we're utilizing some kind of a man-made material to create the connection between the artery and the vein. Goes in the same place, right? Forearm, right? It takes a little bit longer to heal because we're putting something like a foreign object into a patient. But they do last longer usually. And basically assessment of both of these is exactly the same. Feel the thrill, hear the bruit, okay? For any of you that have ever taken care of a dialysis patient, number one, you can sometimes see under the skin the bulging of that vascular access site. And I'm actually going to take some real photographs and put them in this PowerPoint right after this slide so that you can see what they look like. When you touch the site with your hand, it vibrates. It vibrates. That's the thrill. And that's why we say, feel the thrill. So you can touch it and for some patients, especially people that are like super, super skinny, bony, sometimes you can feel that vibration if you're just next to them. You don't even have to put your hand on the site. But that means that it's working. That means that it's in good working order. So that's feel the thrill. And then hear the bruit. The word bruit, I know it looks like bruit, B-R-U-I-T, it's French. It means turbulent blood flowing. So when you take your stethoscope and put it to the vascular access site, you're going to hear whoosh, 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 turbulent blood flow. So you're always going to assess the site before the patient starts dialysis, okay? And you should always document that the thrill and the bruit were present. That's critically important. When we talk about therapeutic interventions for peritoneal dialysis, now peritoneal dialysis is completely different than hemodialysis, okay? So this kind of dialysis can be performed at home. When the patient has peritoneal dialysis, I'm actually going to go to the slide with the picture first. What we do is we surgically implant almost like a catheter into the patient's abdomen, okay? And that catheter can be opened and a catheter tube can be attached to it. And that catheter goes right into the patient's peritoneal cavity. The peritoneal cavity is that whole big abdominal cavity that's surrounded by the peritoneal membrane that encompasses all of your digestive organs, your small intestines, your large intestine, your spleen, and your liver, and your gallbladder, your appendix, all that good stuff is there. But there's room in there. And the peritoneal membrane that surrounds it acts as a filter, if you will, okay? Like a permeable filter. And so with peritoneal dialysis, and this the patient will do at home, usually they'll do it at bedtime because it's a long process, hours, 10 hours, sometimes 12 hours. They will take a bag of dialysate, that is the dialysis fluid. It's in a big bag, right? Usually 2,000 milliliter bag. It will be hung to gravity with the tubing coming from the bag into that catheter, into their peritoneal cavity, and they'll unroll the clamp, and that fluid, that dialysate, will flow into the peritoneal cavity. And you can actually watch the abdomen kind of get bigger and bigger and bigger as the fluid flows in. Once all the fluid is in, then that bag gets removed, and there's something called dwell time. Dwell time is how long the fluid needs to sit in the peritoneal cavity, because while it's in there and using that peritoneal membrane as a filter, it's osmotic. So it's pulling toxins through that membrane into the fluid so that at some point after the dwell time is over, another catheter will be attached to the catheter that goes into the patient's abdomen with a bag, an empty bag, that's hanging down to gravity. And they will actually drain all of that fluid out of the peritoneal cavity, and while draining the fluid, draining all the toxins as well. Okay, so that's peritoneal dialysis. Make sure you remember the number one potential adverse effect of peritoneal dialysis, peritonitis, which is an infection of that peritoneum. Okay, that can be deadly, by the way. Let's see, I want to talk a little bit more about hemo versus peritoneal. And with peritoneal dialysis, a couple things to remember. Number one, the dialysate should be at room temperature. And when they look at the bag of fluid, which should always be inspected before it's used, it should always be clear. And if it's not, it needs to be disposed of, okay? So check the bag for sediment, discoloration, make sure we check the expiration date, all that good stuff. Should be at room temperature. After the dwell time and when the dialysis is being drained from the patient's peritoneum, that should be inspected as well. Because if that looks cloudy or discolored or has sediment in it, that is a big, huge red flag warning sign that the patient could be experiencing peritonitis, which again, that infection needs to be treated immediately. The next slide gives you some nursing diagnoses that are associated with chronic kidney disease: excess fluid volume, always, impaired skin integrity, activity intolerance. Let me tell you something. If it's hemodialysis, the patient will be going to dialysis 3 days a week: Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday. And they're at the dialysis center for at least 4 hours, sometimes 6 hours, okay? They're always weighed before dialysis starts because we want to see how much fluid they're holding. And remember, the weight is the only real true measure of fluid retention. And they will find that after they're dialyzed, they've lost weight because the machine, the dialysis machine, is pulling the fluid off of the patient along with the toxins, right? It's doing the thing that the kidneys aren't able to do. We always want to make sure that the patient, gets enough rest. It's exhausting. Hemodialysis and even peritoneal dialysis, really. People that are on hemodialysis, that 3-day-a-week schedule, dialysis on Monday, Tuesday they're exhausted. Dialysis on Wednesday, Thursday they're exhausted. Dialysis on Friday, Saturday they're exhausted. And when I say exhausted, sometimes they won't even get out of bed. It is just draining, absolutely exhausting. And with peritoneal dialysis, even though they're doing it at home and they're not leaving their house, still you're talking about 8, 10, 12 hours, sometimes 14 hours to have to lie there, have the fluid pour in, the dwell time, then have the fluid drain back out. It's exhausting. It's really a terrible, terrible, terrible way to live, I promise you. Let's see. Nursing care. I mean, you go on and read the rest of the slides. Weight is the one way to tell, how the patient's doing as far as fluid retention is concerned. It's critical. Real quickly, when we talk about medications, now remember, with chronic kidney disease, kidneys have failed, and the kidneys cannot make erythropoietin. So without erythropoietin, the bone marrow can't make erythrocytes, so then you don't have enough red blood cells, which means you don't have enough hemoglobin. And the treatment is epigen, epoetin alpha, and it's given as a subcutaneous injection, and it's usually given weekly. So, and you should know this because these are the med templates that y'all should have done. So with it, it should be given on a non-dialysis day. Because if I give you the epoetin alpha on a day that you're going to dialysis, I'm just going to dialyze it right out of you and not give it an opportunity to get to the bone marrow to stimulate the production of red blood cells. And by the way, bone pain, one of the #1 side effects because the medication is going right to the bone marrow. Makes sense, doesn't it? Okay. And then when we talk about effectiveness, for therapeutic effectiveness, well, what's the patient's red blood cell count, hemoglobin, and hematocrit? Have they increased? If they have, then the drug's doing its job, right? It only makes sense. So make sure you know all that. And I think the next few slides are just kind of questions and answers, review questions and answers. So make sure that and they're good questions too on these slides. So make sure that you go through those questions and answers. And that, my friends, is the end of this part of the program. So if you have questions, remember, pause. Just hit pause and you can text me and we can talk about it. I'm going to take a lunch break because I need to eat something. And I'm going to come back around 1 and open up for questions. Okay? Now about 1:15. Okay? Till then, see ya. Bye.